Good afternoon. I'll be talking today about approach to headache. As we know, headache is the one of the most common symptom with which a person comes to the hospital. Though it might be very common and unalarming symptom, in some cases it can be life-threatening, and hence it's important to recognize that. So today we'll be looking into the pathophysiology of headache. How do we clinically evaluate and investigate patients with headache? And a little bit about primary headaches and secondary headaches. So, as pain from any part of the body, uh, there are pain pathways which perceive pain from pain producing structures in the brain or the central nervous system. So, the pain producing structures are the scalp, the dural sinuses, the meningeal arteries, and the peripheral terminals of the trigeminal nerve. So, headache occurs either due to damage to any of these structures, so that might be because of secondary causes, or it can be because these structures, the nociceptors or the pathways, are activated inappropriately, leading to a headache symptom. So, while clinically evaluating a patient with headache, we look for something known as red flag signs. So, we need to know that if this headache is an unalarming symptom or it's insidious or more life threatening symptom. So, when a person comes with an acute headache and the person says that it is sudden in onset, it's the first severe headache and it's the worst headache, and they have vomiting which is preceding and is associated with the headache, and that's a red flag sign and it requires immediate attention to that symptom. Person with a headache, say for 2 or 3 weeks, it is subacute. However, they're saying that the headache is increasing in intensity and it's increased by bending, lifting, coughing. So these activities increase the intracranial tension and pain, which disturbs sleeps, or it's more when the person gets up in the morning. It's called early morning headache, which is suggestive of an increasing intracranial tension. Would hint you that this headache requires further evaluation. People with known systemic illnesses like people with diabetes, hypertension, or any other immunological conditions require further evaluation of their headaches. People above 55 years, people with fever or unexplained systemic signs also require evaluation of their headaches thoroughly. And if there is any abnormal neurological symptom or sign, like weakness of any arm, weakness of one side of the face, that would advocate further testing or further evaluation of the headache. So, especially in elderly people, if they come with a unilateral headache, especially over the temple or temporal region associated with the cord-like tender structure, you think of temporal arthritis, and it's a vision-threatening condition and has to be recognized early and treated early for a good prognosis. So the first, here are a list of investigations that we like to do when patients coming with headaches. So the first one would be checking the blood pressure of a person. So a high blood pressure can present with headache quite often. So the second would be by doing a fundoscopy, which can be done bedside. This is to look if there is any papilledema, which would indicate a raised ICD. In patients with either red flag signs or with chronic headaches, imaging either using a CT of the brain followed by an MRI of the brain would be required. Patients with fever, any other systemic symptoms suggestive of meningitis leading to a headache, a lumbar puncture is advocated. So now we'll look into something known as primary headache symptoms. So primary headache syndromes, they are multiple, but we would focus on these three common types that would include migraine, tension type headache, trigeminal autonomic nephralgias. So, tension type headache is the most common headache syndrome encountered all over the world, followed by migraine, which is a common headache syndrome but is quite disabling, and hence I put that first, and we'll be discussing about it a little bit more in detail. So coming to migraine, migraine is a headache syndrome, as we all know. It's the second most common cause of headache worldwide. So migraine has basically four phases. First one is the premonitory phase, followed by a phase of aura, that is followed by a phase of headache and a post-stroke. So we'll look a little bit about the pathophysiology. So it occurs because of activation of cells in the trigeminal nucleus, releasing vasoactive neuropeptide, especially one of it known as calcitonin gene-related peptide, it's known as CGRP, at the vascular terminals of the trigeminal nerve. Vascular terminals basically run along the meningeal arteries, and as we had seen previously, meningeal arteries are pain-sensitive structures. So this is responsible for the headache per se, but the premonitory, the aura phase is because of dysfunction of the monoaminergic sensory control systems located in the brainstem and the hypothalamus, especially the nucleus ceruleus. So what are the premonitory features? These occur, say, a few days before the headache comes. So the person might have some neck discomfort, have some cognitive impairment. They'll not be able to concentrate on their work, they have mood changes, they feel really tired, they have cravings, they feel really sleepy, they might be really thirsty or have polyuria. So this is followed by a phase of aura. So what is aura? Aura is basically a sort of a scintillating scotoma which we are able to see just a few hours before the headache, which is followed by a headache phase. They have headache phase has not only pain, it can have nausea or vomiting sometimes. You have sensory sensitivity like photophobia, phonophobia, osmophobia, allodynia, and sometimes vertigo. So once the headache resolves, they have a phase known as post-stroke phase. It is characterized by tiredness, weariness, and cognitive. So how do we diagnose uh, migraine? So here is a simple diagnostic criteria. Migraine is diagnosed by a person complaining of repeated attacks of headache, which last from 4 hours to 72 hours, a normal physical examination, and no other reasonable cause for headache. And they should have at least two of the following. That is, the headache should be unilateral, it should be throbbing, should be aggravated by movement, and should be moderate to severe in intensity. And they can have nausea, vomiting, or photophobia and phonophobia as associated features. So going to the next slide. So how do we treat migraine? So treatment of migraine can be divided into two. The treatment of acute migraine and prevention. So the treatment of acute migraine depends on the intensity, if it's mild, moderate, or severe. Mild attacks, simple analgesics like acetaminophen, aspirin, and caffeine coming in combination can be given, or NSAIDs can be given. That might include naproxen, ibuprofen, dolphinamic acid, and diclofenac. And I mentioned the doses in this on the right hand side. However, for moderate to severe intensity episodes of migraine, we would require something known as the 5-HT1B1D receptor agonists. They are known as triptans. So triptans can be selective and non-selective. Non-selective triptans include the ergotamines, and the selective ones are the triptans, as mentioned. Naratriptan, rizatriptan, sumatriptan, fluvatriptan, almotriptan, electriptan. So triptans can be available in different formulations. It can be given orally, nasally, and parenterally. So among oral triptans, the triptans the highest efficacy are rizatriptan and elatriptan. Though other triptans also have equal efficacy, they might have slow onset. And the thing about giving triptans is triptans should be given after the aura phase has ended, otherwise, they'll be ineffective. And because triptans are short lasting, there might be a recurrence of headache 2 hours after the headache stops. And hence, they have to be uh, I mean, complemented by long acting NSAIDs. One of the most common side effects of triptans is nausea. And among though rizatriptan and liratriptan are very effective, we have sumatriptan and zolmitriptan in other forms, that is the nasal forms, especially in patients with nausea and vomiting, can be given easily. Patients with severe continuous headache can give subcutaneous sumatriptan, 6 milligrams sub-Q at the onset, and dihydroergotamine also. Dihydroergotamine can also be given intravenously, and it's said to have really good absorption intravenously compared to the oral. However, triptans are contraindicated in patients with coronary artery disease and cerebrovascular accidents because they lead to severe vasoconstriction, and hence these group of individuals, triptans cannot be used. Alternative therapies are indicated. So some of the newer drugs, as we had seen previously, are known as calcitonin gene-related peptide receptor antagonists, and that's Japan's. So these are quite recent, and they can be given orally. One is known as rimegepant, other one is known as uprogepan. So rimegepant is given 75 mg once daily orally, and uprogepan is given 500 to 100 milligram orally, a second dose 2 hours later. So, except for some amount of nausea, it is quite safe. Can be given in people with coronary artery disease or stroke. There's another group of drugs known as 5-HT1F receptor agonists, known as DITANs. There's just one oral drug under that, it's known as lasmiditan. And the thing is that, as opposed to triptans, lasmiditan can be given in patients with coronary artery disease as it does not lead to severe vasoconstriction and has very minimal side effects. Going to the next slide. So dopamine receptor antagonists, these usually are given to control the nausea and the vomiting associated with migraine. So some of the common oral drugs are metoclopramide and chlorpromazine. So opioids can also be given, but quite habit forming and as we omitted. Other therapies that we have seen, which are quite new and known as neuromodulation. These include single pulse transcranial magnetic stimulation, non-invasive vagus nerve stimulation, which have been used and found to be very effective in especially severe refractory migraines. Remote electrical neuromodulation and transcutaneous supraorbital nerve stimulation is also being used, though not available widely. So coming to preventive treatment. So when patients have migraine for more than 8 days, like the total duration going for more than 8 days per month, or on more than 15 days per month, are known as chronic migraineurs. And as migraine is quite disabling, some amount of preventive treatment has to be administered to these group of patients so that they can continue their daily living activity. So the group of drugs used for these are the first one are the beta blockers, propranolol, metoprolol, followed by antidepressants like amitriptyline, tocilizumab, nortriptyline, and venlafaxine. Anticonvulsants like metoclopramide, valproate. So coming to beta blockers, quite safe and effective, but history of bronchial asthma has to be taken and it's contraindicated efficacy. Antidepressants are also quite effective, with the only side effect of at leading to a little bit of drowsiness and sleepiness, and hence has to be taken 12 hours before the person wakes up. Coming to anticonvulsants, topiramate and valproate are preferred. Topiramate, though quite effective, can lead to paresthesia, weight loss, and patients with history of glaucoma or on treatment with glaucoma have to get their intraocular pressure checked before this drug being prescribed. And hence, and as there is an increased risk of nephrolithiasis, patients should be counseled regarding the same and should be asked to keep themselves hydrated. Coming to valproate, though quite effective, can lead to a variety of side effects like weight gain, tremors, hair loss, and especially in women of childbearing age can lead to teratogenicity and hence that. Other drugs include CGRP antagonists like eptinezumab, erenumab, fremanezumab, and galcanezumab. All these are given parenterally, though at intervals of 1 to 3 months. The rimegepant can also be used 75 mg every other day, and all this can lead to nasopharyngitis, the monoclonal antibodies. Other drugs are flunarizine, candesartan, memantine, and melatonin. Neuromodulation with the single pulse transcranial magnetic stimulation is also effective. Chronic migraine, onabotulinum toxin, that is Botox, is also being tried. The drugs given at the end, that is verapamil, nimodipine, clonidine, SSRIs like fluoxetine, though have been recommended previously, have not been found to have any effect. So coming next to tension type headache. So it is the most common type of headache which we encounter in the profession department. So it is same as migraine, but it is featureless. It just has a headache, can be unilateral, bilateral, or monocranial, and can be described as a band-like sensation. Usually self-limiting. However, if present for more than 15 days per month, it's known as chronic daily headache. And though tension type headache can be managed with simple analgesics, chronic daily headache requires tricyclic antidepressants like amitriptyline to be given and can lead to a problem of persistent drug use related headache. So coming to trigeminal autonomic epiphalgias, these are short lasting headache attacks. So they're usually either unilateral or can be holocranial with relateralized autonomic cranial symptoms like lacrimation, conjunctival injection, oral fullness, or nasal congestion. So people with trigeminal autonomic epiphalgias are usually misdiagnosed as sinusitis. However, the however, the patient does not respond to treatment of sinusitis, and hence it's important to keep this in mind. Another thing is that patients with pituitary tumors can also present with symptoms suggestive of trigeminal autonomic epiphalgias, and hence people with new onset attacks have to undergo an imaging to look at the pituitary and pituitary function test. Moving to this slide, so we'll be discussing three most common causes of trigeminal autonomic epiphalgias. The first one being cluster headache, followed by paroxysmal hemicrania. The last one being sunk or solo. Some being short-lasting unilateral neuralgiform headache associated with conjunctival tearing and lacrimation. Suna is short-lasting unilateral neuralgiform headache associated with the autonomic symptoms. So coming to cluster headache first. So it is the only headache syndrome which is more common in males. Migraine is more common in females. However, cluster headache is more common in nails, described as stabbing or boring pain. It's excruciating, localized to the orbit and the temple. The frequency of attack can be one per day or maximum of 8 attacks per day, with each attack lasting for around 15 to 180 minutes, and is associated with autonomic features that we had described previously. They might also have features suggestive of migraine, and alcohol consumption usually increases cluster headache. However, there are no cutaneous triggers which can exacerbate or provoke this headache. And the treatment, that is the treatment for the acute cluster headache, which is very effective, is oxygen therapy, though it cannot be available all the times. So triptans, especially the nasal spray, are quite effective in the treatment of cluster headache and are recommended. Non-invasive vagal nerve stimulation can also be used in severe treatment refractory cluster headaches. So for prevention of cluster headaches, the drug which is indicated is verapamil. It's a calcium channel blocker. Other drugs can be galcanezumab, that is CGR, the antagonist, topiramate, melatonin, and lithium. So coming to paroxysmal hemicrania, it's also a trigeminal autonomic epilepsy. It's common in both males and females. It's described as throbbing, boring, stabbing pain over the orbit and temple. You have around 1 to 20 attacks per day. Usually the attacks are more than 5 per day, and each attack lasting for around 2 to 30 minutes. They can have autonomic features and migrainous features. However, this headache is found to be responsive, very much responsive to one steroid anti-inflammatory drug, that is indomethacin, and hence can be used in preventing episodes of paroxysmal hemicrania in these patients after diagnosis. Coming to the last, that is sound or sonar. It's common in both males and females. It's quite rare. Can be described as burning, stabbing, sharp, severe, excruciating pain, usually over the periorbital area. And we have from 3 to 200 such episodes per day, each episode lasting from 5 to 240 seconds. It's quite short, frequent attacks. And they have prominent conjunctival injection and lacrimation, migrainous features, and can be triggered by cutaneous stimuli. So, for abortion or the acute treatment of samtoxanone, IV lignocaine is recommended. However, for prevention, lamotrigine, topiramate, which are anti-epileptics, can be used, and gabapentin can also be used for prevention of this. So, coming to secondary headaches, there might be so many causes of secondary headaches, but I have listed the 5 most important causes that we should keep in our mind and we should always be on the lookout for when we are taking history and examining the patient. The first in this list is meningitis. I'll give you a case vignette that is usually middle aged patients, either males or females. They usually have a history of fever, which is followed by headache and neck pain. And they have features of increased intracranial tension. The headache increases on bending, coughing, sneezing. It's more in the morning. They might have vomiting associated with it. Might become quite unwell over a short period. Meningitis is a medical emergency. patients have to be admitted, have to get investigated initially by doing blood tests like complete blood count, CRP, blood cultures, and it will be followed by an imaging of the brain of endoscopy to rule out any increased intracranial tension and a guarded lumbar puncture and analysis of the cerebral spinal fluid to look for the counts, the cell counts, which are elevated, the protein will be elevated, the glucose level will be less than 40, and a culture is sent and a gram staining is sent to look for either gram positive, gram negative organisms, and they are empirically started on antibiotics. So that is about meningitis. Second, talking about intracranial hemorrhage. So among intracranial hemorrhages, as we know, that might include subdural hematoma, and extradural hematoma, subarachnoid hemorrhage, and an intralobar bleed. So among these, subarachnoid hemorrhage is an important cause that we have to keep in mind. So patients, usually young patients, present with sudden onset headache when they're doing say some strenuous activity or the height of any excitement. Present with severe headache, the worst headache of their life is how it's been described. The term given to it is known as thunderclap headache. Patient has neck pain, some vomiting, and they present to emergency department. The first investigation that we do is non-contrast CT of the brain to look for enhancement of the cell side direct that will indicate a subarachnoid hemorrhage. If an MRI is present, then that would be the first thing. In case it's not detected by a CT scan, we go ahead and do a lumbar puncture, see if there's any xanthopenia. So, subarachnoid hemorrhage can be is usually because of rupture of an aneurysm and requires further contrast imaging and treatment, either clipping or coiling of the aneurysm to arrest that bleed and prevent further transfusion. So next, it is a condition known as temporal arteritis. It is a condition seen especially in females over 65 years of age. They present with headache, which is usually unilateral over the temporal area, and they might also have symptoms suggestive of polymyalgia rheumatica, that is fatigue, fever, joint pains. So this headache has to be recognized quite early, even in the first visit. Have to examine for tender temporal artery, tender, which is cord-like and tender. And if diagnosed, we have to send bloods, like especially ESR, which will be elevated. And treatment for this is intravenous high dose glucocorticoids. It's important to recognize and treat this because it's a vision threatening. It can lead to loss of vision on the side of the headache, and hence it's important to start steroids when temporal arteritis is suspected. A confirmatory test is a biopsy of the temporal artery. Because the lesions are skip lesions, the biopsy can be negative, and the patient might have to undergo a second biopsy to confirm the cause as temporal arteritis. The fourth one is glaucoma, especially angle closure glaucoma, which can present with severe headache, conjunctival injection, diminution of vision. So it's very important to keep this important secondary cause of headache in mind when seeing patients, especially when other neurological examination is normal except for the eye. It's important to involve the ophthalmologist, check the intraocular pressure, and to promptly do an iridotomy to reduce the pressure. The fifth and the last is a brain tumor. Brain tumor is known to be the only presenting complaint of, sorry, headache is known to be the only presenting complaint of brain tumor and 30 to 40% of patients with an internal space annihilation. So usually not very alarming, can be something of a chronic headache, and towards the end they might have features suggestive of an early morning headache, nausea, occasional vomiting, which is projectile. They might have increase in headache with coughing, sneezing, straining, all these activities which lead to increase in the intracranial tension. So I hope this lecture would given you an idea about headaches, primary, secondary causes of headaches, briefly about the pathophysiology and the treatment. Please let me know if you have any doubts.